Collaborative to provide AMA allopathic CME credit for physicians, and by the Virginia Nurses Association to provide nursing CE credit. The program was developed to promote two desirable physician attributes, those being our providing patient-centered care and employing evidence-based medicine in our practices. Dr. Obianozi and Dr. Honea, myself, and the members of the Sovah Health CME Committee have no commercial relationships to disclose to you this evening. The program has no commercial support, but is supported, as are all of our programs, by an educational grant from the Ralph Landis Medical Education Fund, which resides at the Danville Community College Educational Foundation. Dr. Landis, who founded the Southside Urology Danville Urologic Clinic, upon his retirement, he made a donation to our local hospital that later was managed at the foundation to provide continuing medical education throughout our community. And to him and his generosity, we continue to be very grateful. This evening, after the program, you'll receive by email an evaluation form. We ask you to take a few minutes to complete that. It has 7 questions. On that list of questions, number 4, which asks, what if you learned something this evening, what did you take from the experience that will be something you'll be changing in your practice? This is for everyone, not just the physicians on the call. We all care for patients and practice medicine in our own scope of practice. So be sure and take a few minutes and share with us what you may be doing differently as a result of the program. The eval form also asks you to re-enter your name and your email address. This is the way we're able to send you your certificate of attendance. So please put your full name, no nicknames or short names, so we can get it correct on your certificate. I need to remind the nurses, nurse practitioners on our call that your completing an eval form is required by the Virginia Nurses Association for you to receive credit for the program. Eval forms are voluntary for physicians and others on the call. We do take the evaluations very seriously, and we appreciate you doing these. And in addition, we have a QR code that Mary will send out through the chat in which you can access the eval form that way if you prefer to do it that way rather than waiting for the email coming to you. You will receive, subsequent to that, a CME certificate. I always remind our medical residents at Sovah Health on the call that your residency coordinator, Dara and Lori, are tracking your attendance to these programs, so you do not have to worry about getting the certificates and collecting them, etc. Also, every time we do a program, I like to take this point in the introduction to thank Mary Ken and Vandora Holt for their help in organizing the program this evening. Quite honestly, they do most of the heavy lifting of the process, forms, etc., and for their support, I really am very grateful. We encourage questions. I know both the speakers tonight would like to have you ask things or make comments. If you ask a verbal question, we ask you to mute your phone to listen to the response so we don't get feedback. You're urged to do as many comments and questions as possible. In fact, it really enriches the overall program if we can have some interaction between the participants and the speakers this evening. You also can put them in the chat. Mary will monitor that, and she'll forward those and get them to the speakers just as soon as they appear on the chat line. That reminds you of a couple of upcoming programs for next month. On April 10th, we're delighted to have Dr. Barry Friedman as our speaker. Dr. Friedman is the chairman of the nephrology section at Wake Forest University Atrium Health in Winston-Salem, North Carolina. I know many of you are aware that there's a high prevalence of end-stage renal disease in our community, and historically, patients who are African American have a greater risk of end-stage renal disease than do other ethnic types of individuals. new research that's just been emerging, of which Dr. Friedman was a part, has identified a specific set of genes that predicts that, and he's going to be sharing not only that, but what is a huge amount of emerging information that many forms of the inherited renal diseases we have known for years, understanding their genetic basis is now being elucidated. Many things that we used to feel as were idiopathic, membranous glomerulonephritis, other things, polycystic kidney disease is now totally understood, including the pathophysiology. So this is something that's really a really new revelation about understanding why some individuals have increased risk. And Dr. Friedman was on a landmark article published just a few months ago that detailed this whole understanding about the risk of having renal disease if you have a certain gene pattern. And then the second talk next month is by Dr. Pawa, who is a hospital medicine physician at the Johns Hopkins Hospital. One of the things that's emerged over the past 10 years has been the concept of value medicine. In other words, those diagnostic tests and those treatments that we do that truly can make a difference. This comes down to such simple things as how frequently do you do repetitive chest x-rays in a hospital with someone with pneumonia or daily lab work in an ICU. Dr. Pawa is an expert at this, and we want him to help us understand the best choices we can make to provide not only safe and effective care, but high value medicine to the patients that we care for each day in the hospital. Well, that leads me to having the privilege of introducing the two speakers to you tonight. They're going to do, if you will, a tag team approach to this, and I want to briefly introduce both of them so they can just, if you will, run with the program. Dr. Promise Obinozi is one of our internal medicine residents. She originally began her educational journey at the East Carolina University in Greenville, North Carolina, where she received her BS degree in molecular cell biology. She worked for a time as a research assistant there. In addition, she was selected as an undergraduate as a teaching assistant, what's known in the business as a TA. That's a huge honor. That says you communicate well and you're the best of the best in teaching. She also was a resident hall advisor, something I was also in Carolina, which again is a sign of leadership and trust in her ability to help others. She completed her MD degree at St. George's University School of Medicine, where again she was chosen as an academic enhancement peer tutor, someone who actually was chosen to help first and second year students when she was a senior student on their in their acclimation to medicine and to the medical school world. That'll be followed by Dr. Philip Honea. Dr. Honea, who I know many of you on the call already know well, and he began his journey in medicine at the Montreat College in Western North Carolina, where he received a bachelor's degree in environmental science. He graduated cum laude and went on to receive his DO medical degree at the University of New England College of Osteopathic Medicine. He too was chosen as a teaching assistant in medical school, and he received two very unique awards, which truly reflect his whole approach to providing care. He received the School of Medicine there's Sorter Award, which was the person chosen by the faculty who they would choose to be their family physician. And secondly, he received the award of commitment to service, reflecting his ability in training peers on very meaningful doctor-patient communication. He then went on to complete his OBGYN residency at the Michigan State University's Mercy Health Muskegon hospital system and has been in practice here in Danville for a number of years. The other wonderful thing that Dr. Honea does is he freely volunteers his time along with his father, who I know you know, Dr. Robert Honea. They are both recurrent medical missionaries for Samaritan's Purse program, the Billy Graham program in Africa, where they regularly and repetitively go to provide healthcare services, surgical and OBGYN services to those individuals in Africa who have those needs. It's just a delight to have both of these bright, young, effective communicators and good docs to talk with us tonight. So, Dr. O, as she's known lovingly by her associates, if you'll bring your slides up, mine will pop off, and we invite you to begin the program. Thanks so much.
Thank you, Dr. Moore. I appreciate that. So I'm going to share my slides real quick. Can you guys see it?
Hold on. Yeah, they're coming. Yeah, then just go to hide presenter view.
Is that, can you guys see the slides now?
Yeah, we can see it along the side too. So you want to go to the bottom of the slide and go to where it says hide presenter view. Do you see that? Or you can go to the screen down here at the bottom, the full screen, and go to that. Right along that lower ribbon, bottom right hand. Yeah.
Here, right? This one?
Or go to slideshow at the top ribbon and from the beginning.
Okay.
Yeah.
Okay. Is this perfect? Is that okay or no?
No.
Oh, yeah.
Just along the top where it says home, insert design, go over to slideshow at the very top.
Slideshow. Let me see. At the top of the screen or?
Yeah. You know, can you see file and home and insert design,
no,
all those options?
I don't see that.
Okay. What about at the bottom? Can you see your options to go? Yeah. Click on that.
So this is perfect, right? This should be good.
There's a little cup-like icon bottom right that will do it. Looks like a little stand.
Hold on, just.
Is that okay or no? Is this what you're talking about?
No, you're still not in presenter mode.
Oh, it's not in presenter mode. Okay.
Hold on.
Show presenter view. Is this okay?
Why don't you take your slides down?
Okay.
For me.
Let's see how to take this.
You may be able to knock her off, Mary, with yours.
I'm going to end the show and I'm going to stop sharing. You want me to stop sharing or?
Yeah.
Yeah.
So, I'm sorry, guys.
Oh, you're doing fine. It's fine.
So I don't see that. I'm going to go back to this and I'll stop. All right.
Okay, now you're on.
Okay.
Oh, hold on. Okay, so now you need to take control of the slides. Do you see that option at the top?
Yes.
Okay, so
do I have control of it?
And now you'll be able to advance them. Okay.
Okay. Sounds good. Thank you, guys.
You're welcome.
So my name is Dr. Promise Obianozi. I'm one of the internal medicine residents. And thank you, Dr. Moore, for that awesome presentation. So I'm going to go ahead and get started. So today we're going to be talking about gestational hypertension. We'll talk about preeclampsia and eclampsia. We'll also talk about the incidence of hypertension in pregnancy, and we'll talk about the chronic hypertension in pregnancy and the definitions of each of those. And then Dr. Honea is going to take it off with management and clinical scenarios. So hypertension in pregnancy, this is one of the most complications that occur during pregnancy and typically occurs in the early postpartum period. There are several types of hypertensive disorder, pregnancy disorder that we have, and each of those have its own specific definition based on ACOG guidelines. And we're going to be talking about a little bit about each of those. So today we'll start off with chronic hypertension. What is chronic hypertension? So it is defined as hypertensive disorder that occurs before 20 weeks of gestation. Any type of hypertension that occurs before a gravid female hits 20 weeks. Typically, you see most incidents occurring in African American females who are obese, who have increased maternal age. And one of the things that we've seen over the years between 2008 and 2021 is there has been an increase in hypertensive disorder in the last few years. This study that I just wanted to highlight was based on the commercial insurance claims from live births occurring between 2008 and 2021. And it was showing that there has been at least 1.8% to 3.7% increase in chronic hypertension in females in general. And labetalol is what has replaced several other medication that has been approved for hypertension in pregnancy. And one of the things I just wanted to highlight is the incidence that is mostly seen in that African American female, and also it's just largely due to obesity and sometimes due to increased maternal age. And I'll go to the next slide. So this is the American College of Obstetrics and Gynecology definition of hypertensive disorder. And first of all, it's a systolic blood pressure of greater than 140 or a diastolic of greater than 90. And this has to be on two separate occasions, at least 4 hours apart. So that's how you diagnose hypertension in pregnancy. Or it can be a single blood pressure reading over 160 or a diastolic blood pressure reading over 110 on just one reading. Chronic hypertension, we've already talked about, is a hypertension that occurs before 20 weeks of gestation and that is diagnosed for the first time during pregnancy. And we can also see some chronic hypertension with some superimposed preeclampsia, and we can talk about it down the line when we're going to see it in the next upcoming slides, what that is. So I'm just going to highlight a little bit about the definition of gestational hypertension. Like we talked about previously, it's a systolic blood pressure reading over 140 and diastolic over 90. And this has to be on two separate measurements, at least 4 hours apart. There shouldn't be any proteinuria or end organ damage. When you start seeing some proteinuриas, that's when you start, calling it preeclampsia. Now, this type of hypertension is diagnosed after 20 weeks of gestation. Patient has no prior history of hypertension before. They just developed this blood pressure reading after they're already 20 weeks. Now, this type of hypertension should not persist longer than 12 weeks postpartum. If it does persist longer than 12 weeks, then there is a secondary cause of hypertension. So I'm just going to talk a little bit about the preeclampsia. What is preeclampsia? We've already established the diagnosis of hypertension, which is greater than 140 and greater than 90 diastolic. Now you have to start seeing evidence of end organ damage, and that's like a proteinuria, or some severe features like platelet counts of less than 1,000, elevated liver enzymes, or elevated baseline creatinine that is doubled. Those are severe features that will give you very warning signs that that you have to follow this patient up closely. And then I'll talk briefly about eclampsia. Now, this is a very scary diagnosis. When you have eclampsia, you're going to start to see some new onset seizure. At that time, patient does not have previous or prior history of seizure. This is any type of tonic-clonic or focal or multifocal seizure. And of course, definitely you already ruled out other causes of seizure like alcohol-induced seizure disorder or any type of ischemia or hemorrhage. So you've already ruled that out, and this is like a new onset seizure occurring in a gravid female who is over 20 weeks of gestation. Now, this has to occur in the presence of hypertension, some proteinuria, which is a preeclampsia, as well as a new onset seizure. And this slide that I just wanted to show was just some definitions of preeclampsia. It's just to tie everything together. And this is to define what proteinuria is. And it's like a greater than 300 grams of protein in the 24-hour period, or a dipstick reading of greater than 2+ proteins. You can also see some platelets, like we talked about, less than 100,000. This will start telling you that this is preeclampsia with severe features. You see a serum creatinine of greater than 1.1, doubling of baseline creatinines, and some symptoms like new onset headaches, some vision losses, and other, scary neurological signs. And this one is more of my last slide, and I just put it out there. It's like a very nice little chart that puts everything into perspective. And the only thing that I just wanted to highlight on this chart was to show some of the complications that you can see in patients who have preeclamptic phases or eclamptic phases, or like chronic hypertension in general. You start to see those complications occurring in the fetal, which can pose as oligohydramnion. You can see intrauterine growth restrictions. The baby weight, it will be below the gestational age. And sometimes you can see intrauterine fetal death. And now the other thing that I just wanted to point out is just a very nice little chart. That chronic hypertension has to occur less than 20 weeks. When it's gestational hypertension, it occurs greater than 20 weeks. And when you start seeing evidence of proteinuria, that's when you start seeing the preeclampsia with some severe features like the creatinine and the transaminases. And then when you see eclamptic features, it will occur with seizure-like disorder as well as neurological signs as well. Now, I'm going to let Dr. Honey take over the next slides. Thank you.
Thank you, Dr. O. I think if you give up control, I'll be able to take it over from you.
No, you just click on the button that says take control. Oh, no. Let me bring them up again.
Yeah, it's not giving me that option. I had it when I was on with you Monday.
Okay, it's fine.
I think you had to release control Monday for me to take it over.
It's okay. I'll bring him up.
Okay.
Got it?
I can see it. Can everyone see it?
Yeah, they look good.
Okay, good. All right, so we'll get started going through the spectrum of hypertension disorders in pregnancy. And this is, as Dr. O mentioned, extremely important just because of the prevalence we see of this, and because now we're seeing this as a cardiovascular disease is one of the major causes of maternal mortality in this country. And so we used to be more concerned about things like postpartum hemorrhage, but we're seeing cardiovascular disease surpass that in both maternal morbidity and mortality. And so this is a very serious problem that we need to watch carefully. I'm going to breeze through my initial couple slides since Dr. O reviewed that well. Just before we start, there are some normal cardiovascular changes in pregnancy. And so at the beginning, we see the cardiac output is stable in the first trimester and then increases by 35 to 45% in the second and third trimester. We see the heart rate increase by 15 to 20% in the third trimester. And now with everybody having their watches that are monitoring their heart rates, we get lots of questions from pregnant women saying, oh my God, my heart rate is in the 100s. What do I do? And we have to remind them this is normal. We often see heart rates in the low 100s just at rest in pregnancy. And blood pressure usually decreases by 10% initially, and then will slowly increase back up in the third trimester. So I just had a patient who has chronic hypertension. I just saw her for one of her early visits, and she came off of her blood pressure medicine when she found out she was pregnant. And at her first OB visit, her blood pressure was great, even though she'd been on blood pressure meds for several years. And I told her that I expect as she gets further along in pregnancy, we're probably going to have to restart her on a blood pressure medication because we expect her blood pressure to creep back up as she gets further along in the pregnancy. And then we also see plasma volume increase by 40 to 50% by the second and the third trimester. So these are all normal changes that we'll see in everybody unrelated to hypertension disorders. So just to get into some cases now, because that's much more interesting than facts. So the first case is a new OB visit. It's a 36-year-old. She's a G2 P0010 Caucasian female who she came in for her new visit. And we usually do ultrasounds at the visit. She was 9 weeks and 2 days. And again, all these cases are not any person in particular. I made these cases up based loosely on patients that I have seen. And a lot of these cases I actually simplified so that we could just focus on the hypertension and not get distracted by other comorbidities. So she denies any significant health history and is not on any prescription medications. She's taking prenatal vitamins, and she had one prior miscarriage in the first trimester a couple years ago, and she had a DNC for management, but no other surgeries. On her physical exam, just the highlights here, her blood pressure was 142/84. Her heart rate was 90, her BMI is 36, and the fetal heart rate was in the 160s. And then her exam was otherwise very normal. So when we think about what the diagnosis is, even though she said she had no medical history, the blood pressure being here, that 142 triggers us in to think about chronic hypertension. And so it's just one value, but now what do we want to do in response to that? So she'll get all the routine labs that we do on that first paragraph here is what we do on every new OB patient. And then for her BMI is over 30. So we do an early hemoglobin A1C to see if we need to do early glucose testing. But I would go ahead and get a preeclampsia panel or PIH panel to get her baseline, especially her liver kidney function and urine protein creatinine ratio. And we do that early on a lot of patients who either have pre-existing cardiovascular disease in pregnancy, or even if their blood pressure is in the 130s or 140s, even if they don't meet criteria for anything yet, we want a baseline level because we want to see if their blood pressure increases to severe range later in pregnancy and we repeat those labs, we can compare the repeat labs to what their baseline is. And
Dr. Honea?
Yes.
I'm so sorry to interrupt you. I don't believe that the slides are advancing. I thought maybe it was on my end, but yeah, we've had a couple comments now.
We're just saying the title slide.
Oh, okay. I'm a couple slides in.
Absolutely.
I am so sorry.
If I hit share, maybe if you pass that back to me, I can try to hit share. Will that share my whole screen?
Yeah.
Let's
should. Now see if you can advance.
Oh, here we go.
Okay, are you getting the take control at the top of your screen now?
Let me see. No, I still don't have that at the top, but I think I found where I can.
If not, I'm happy to advance them for you.
Okay, that sounds terrible. Let me see if I can do this.
It's okay.
All right, can you see?
Yes.
And is it changing slides?
Yes. Yeah.
Okay, perfect. All right, let's see.
Thank you so much.
Yes, thanks for letting me know. So here this was where I was at. So this initial paragraph is showing us what we get on everyone. And then I mentioned the personalized labs that we're getting on her because we want to be able to see if she does develop severe range blood pressures later, they go up later in pregnancy, we can repeat labs and compare it to her baseline to make sure we get an accurate diagnosis. And then I would say consider an EKG. If anyone has a history of things like peripartum cardiomyopathy or any kind of significant cardiovascular history in a prior pregnancy or unrelated pregnancy, it's recommended to get an echocardiogram early in pregnancy to see where their cardiac function is at baseline. So as Dr. O mentioned, she needs to have 2 different measurements be elevated to diagnose this. And an ACOG is where we get all of our OB-GYN recommendations. And they still are using the old 140/90 recommendation, but they admit in some of their guidelines that even the other organizations are stricter for non-pregnant people. And so if we have someone who is pre-existing chronic hypertension based on the strict criteria, even if they're not 140 or 90 diastolic, we still keep them designated as chronic hypertension just because we know we need to watch them more carefully in pregnancy. And studies have shown that if someone has blood pressures in the 130s in early pregnancy, they just can't be trusted. And we just are kind of waiting for them to develop a hypertension problem later on. Even if they don't meet criteria, it's been shown that they're more likely to have preeclampsia or gestational hypertension later in pregnancy. So the reality of the practice is normally after the new OB visit, we don't see people for 4 weeks. For someone like this, we would often see them back in a week, at least for a blood pressure check, just to see if they really meet criteria for chronic hypertension, just so that we know. And in our office, we have a mix of OBGYNs and midwives and nurse practitioners who all do prenatal care. And so for important things that we really want to watch, we make sure there pop up reminders in the chart just to make sure that we're giving the best care possible. And then if you did a follow-up and their blood pressures are staying in the 140s to 150s, the recommendations now are to consider starting an antihypertensive medication. Where previously we never started blood pressure meds in pregnancy because we were afraid we were going to mask if they develop preeclampsia later. And so luckily, with one of the perks of being an OB is our medication options are very limited. And so we're not forced to memorize the significant number of antihypertensive medications that are out there. The textbook answer traditionally has been the first line starting with methyl-dopa. That does not work very well, quite honestly. And typically what we do is labetalol and nifedipine are the 2 most common medications that we use. Usually hydralazine is just added if we have to. During pregnancy, a lot of women are going to use up or release their medications a little quicker. They're metabolized a little quicker in pregnancy. And so normally for the extended release nifedipine, we're doing once daily dosing. But in pregnancy, we often do a twice daily dosing. And then labetalol is often given 3 times a day, where normally it's given twice a day. And so we do these more commonly. We have to adjust them. Normally, we often have to increase them as people get further along in pregnancy. And we definitely have patients that end up on 2 or 3 options of these medications at a time just to get them under control, to try to keep them pregnant as long as possible and get everyone that we can to at least 37 weeks gestation. So for monitoring early in pregnancy, other than you may do more frequent visits, or even after you repeat, if the blood pressure's stable in the 140s, you may not have to keep seeing them every week. You may be able to space them back out to every 2 to 4 weeks early in pregnancy. And then as after their 20-week anatomy scan or ultrasound to check all of baby's parts, then we will switch them to growth ultrasound and a fluid check every 4 weeks. And so that's because with pregnancy and hypertension, we often see smaller babies and low fluid. So that's what we're looking for with the Q4-week growth checks. And then if a patient is medicated, if they're on these antihypertensive medications, we want to do weekly NSTs where they're put on the monitor. We watch baby's heart rate for about 20 or 30 minutes starting at 32 weeks. You can start as early as 28, but usually we're able to hold off until 32 weeks. And then otherwise, if they're not medicated, we usually start weekly NSTs or biophysical profiles at 36 weeks. And that biophysical profile is an ultrasound that checks how baby's moving and checks the fluid and looks at the baby's practice breathing in utero. And a good NST and a good biophysical profile will let us know that the baby's not stressed by the hypertension and there's no reason to rush to an induction or early delivery. So delivery timing, if they're not medicated, you can wait to 38 or even get close to 40 weeks gestation. If they're on medications, you could deliver them as early as 37 weeks. So ACOG guidelines give us some wiggle room here to decide where each individual patient needs it. And then if they're very uncontrolled chronic hypertension, where even on medications, we may be seeing blood pressures in the 160s or 170s systolic, that's where we would consider delivery as early as 36 weeks. So some of the risk for the baby with chronic hypertension, like I said, we see more low birth weight or growth restriction. The risk of that doubles. Perinatal mortality is 2 to 4 times higher than in the general population. You're more likely to have placental abruption with high blood pressure. There's limited evidence of possible other congenital anomalies, but that's definitely not definitive, and it's not something that we see frequently. So for the big risks that we really see much more commonly with hypertension problems in pregnancy are risks to the mom. And so that's death and stroke, pulmonary edema. These are all very serious complications. Even things like that you wouldn't think of necessarily. If you have hypertension, you're more likely to have gestational diabetes. You are more likely to end up with a cesarean section with an early induction, and seeing your hypertension progress to things like preeclampsia. So any questions here? I don't know if I'll be able to see them if they pop up in my current view. So I'll give time for questions at the very end.
Dr. O'Neill, this is Dr. Moore. Let me ask you a question. If a patient comes in, a lady, first visit pregnancy, and she's been on 3 or 4 antihypertensives before, drugs beyond labetalol and nifedipine, or would you stop those other drugs and try to just maintain her with the drugs that you're using here from an OB point of view of her blood pressure?
Yes. Yeah. And if she was on something like a different type of calcium channel blocker or a different beta blocker, it's probably low risk to keep them on it, but we do prefer them to be on one of those 3 medications, just because those are the main 3 that we actually have. So many women have been on them that we can put women on it and not worry about side effects. But definitely things like ACEs and ARBs, we want those off because those can cause kidney problems for babies. So we would stop that right away. And so if someone in primary care had a chronic hypertension patient and they were on an ACE or ARB and they had a positive pregnancy test on a patient, we would want them to stop it right away and switch them to something like labetalol, nifedipine, or send an urgent consult to OB-GYN. That way we could give them recommendations to switch.
And the same concern for diuretics. I know one of the ideas is you don't want to make the placenta ischemic, so to speak.
Right. Yep. Yeah. So we typically, and later in pregnancy, there are cases where we use some diuretics, but that's uncommon.
Thanks so much.
You're welcome. All right, so we'll move on to the next case, and I'll stop briefly in between, but I'll give a longer pause at the end of the presentation to review anything or if other people have questions about specific cases. So this is a second trimester visit, so it's a 24-year-old. She's a G3 P2002 African-American female who came in for just a routine visit at 24 weeks. So 2 prior vaginal deliveries. In a prior pregnancy, she was diagnosed with preeclampsia at 38 weeks and was induced at the time of diagnosis. So after that delivery, she did not have to be on any kind of antihypertensive medications. And her current medications, she's still not on anything for blood pressure. She's just on prenatal vitamins and a heartburn medication. So no other significant medical or surgical history. She didn't have any concerns at the visit. And her vitals show 150/88 for her blood pressure, a heart rate of 85, her BMI is 40, and the baby's heart rate is 135, which is normal. So interventions at this time, obviously it's a hypertension discussion, so her blood pressure is up. But again, it's just one level. It's not more than one level like we know that we're required to have. So no prior elevated blood pressure, so she doesn't meet criteria for hypertension in pregnancy yet. But she does have significant morbidity and mortality risk of hypertension in pregnancy. So we would go ahead and order the labs and the blood work and the urine to make sure those are normal. And we would have a close follow-up within the next week, where normally you'd have no follow-up. Usually it's even 4 weeks still at 24 weeks, but at least 2 weeks. Because we just want to check those labs and make sure we're not missing anything and there's no sign of preeclampsia. So we get her labs back the next day, and her creatinine is normal for pregnancy. Her liver enzymes are normal. Her platelets are fine. Her protein creatinine ratio is under that 0.3 that Dr. O talked about, but her blood pressure is over 140. And so now when we see the two blood pressures that are elevated, normal urine and normal labs, she meets criteria for gestational hypertension, but not for preeclampsia. So at this point in pregnancy, she's already 24 weeks. So we would go ahead and schedule a growth ultrasound every 3 to 4 weeks. So typically we try to get her first one done within that next week. So we'd want it pretty quickly. And then we would want to make sure that we're checking her amniotic fluid level once a week, and at non-stress test or biophysical profile 1 to 2 times weekly. That would start at 28 weeks. We wouldn't start that before. And weekly OB visits with preeclampsia lab. Yes. Okay, moving on. So with gestational hypertension, you're just waiting for someone to get preeclampsia. And so that's why we start doing weekly visits with preeclampsia labs. And we often start that, when they're this is pretty early to develop it. Most of the time we see it later on. But that's something that we would start even before we were starting NSTs that would be happening at 28 weeks. So for her case, with elevated blood pressures, it would be worthwhile to start her on nifedipine. And we typically just start on 30 milligrams once daily, since her blood pressures are high, but not scary high. They're still under that 160/110 severe range. And then we would just increase that to twice a day or 60 once a day if we needed to. With gestational hypertension, you do want to deliver right around 37 weeks. And that recommendation they used to give us a bigger span of, from 37 weeks up to 38 or 39 weeks. But now the recommendations, because of the risk of this proceeding into preeclampsia, we want to deliver as close to 37 as possible. And then the maternal fetal risk that we went over earlier that we see with chronic hypertension, those are the same risks we see with gestational hypertension. They're just, we would say, potentially a little more elevated. We're a little bit more concerned about it becoming preeclampsia when it's gestational versus chronic hypertension. Any questions on gestational hypertension?
Nothing in the chat.
Okay. So now we're moving on to a 36-week case. So this is a 32-year-old African-American female. This is her first pregnancy. She's a G1, and she came in for just her routine visit at 36 weeks. And she's had some increased swelling in her legs and her hands in the last week. And she told us that her mother had toxemia when she was pregnant, but the patient herself has no medical or surgical history that we're worried about related to hypertension. She denies any kind of severe headache, vision changes, right upper abdominal pain. And then her only medications are prenatal vitamins and 81 milligram aspirin. And I'll touch on the aspirin later, but because she's African American and it's her first pregnancy, that those two put her at higher risk. And you'll see here her BMI of 45. That's a third thing that puts her at higher risk of developing preeclampsia. We found that if you put women on aspirin, on the baby aspirin, starting around 12 to 16 weeks, we can decrease that risk. So her blood pressure at the 36-week visit was 142/78. Her heart rate's 90, and she had a 12-pound weight gain in the last 2 weeks. And that relates back to what she was reporting with her having increased swelling. And then her baby's heart rate is good, around 145. So we get labs, and her preeclampsia blood work is within the normal range. Her urine protein creatinine ratio is 0.45, and that's elevated. That's over the 0.3. Now, traditionally, we would make people do a 24-hour urine collection. So we'd send women home with these big jugs to keep in the refrigerator. They'd collect their pee for 24 hours and bring it back to the lab, and we would get it measured for protein. But the urine protein creatinine ratio is just a one-time urine sample, and we get that number back. And that lets us know if they're spilling urine the same way the 24-hour urine did. So when we see this, so diagnosis and management with the blood work is fine, but the urine protein is elevated, the blood pressure was over 140. This is where we're concerned about preeclampsia without severe features. Now we would want to see if she had another, to meet criteria. You want 2 of those blood pressures to officially meet criteria. For the sake of the presentation, we'll say we got another one. But for her, she's 36 weeks. So you're going to immediately try to get her on the schedule for induction at 37 weeks. And we would go ahead and do either a biophysical profile, ultrasound, or an NST. And we'd also get a growth and fluid ultrasound on baby just to make sure the fluid's not low or baby doesn't have a growth restriction, make sure there's no reason that we would need a delivery even before the 37-week mark. And then for her, since we just did labs and they were normal, we would just repeat labs at the time of admission for induction in 1 week. So we'd see her back within the week. And then I put here, consider starting a blood pressure medication. Again, her blood pressure is not severe range, but it's something just to think about. And for that level of blood pressure, we would just do 30 milligram XL-nifedipine once a day, or labetalol 200 milligrams twice a day. Those are common starting doses that we use for people with elevated blood pressure that's not scary high. So preeclampsia criteria, like we talked about before, those 2 elevated blood pressures, and that's with proteinuria or with some of these other signs of end organ damage or the neurologic symptoms. And so it doesn't have to be with the protein in the urine if they have some of these other symptoms like the thrombocytopenia, the renal insufficiency, impaired liver function, pulmonary edema, and new onset severe headache or vision symptoms. And again, here's the urine that I mentioned earlier. And so a 2+ protein on a dipstick. So if in our office, if we see 2 or 3+ protein on a urine dip that we check on all of our OB patients, even before I have the other labs, I'm immediately more concerned about her. And that might make me send someone over to labor and delivery to get labs back right away, rather than just ordering through the office where I may not get them hours later or even the next day. So that's something you can look for. Just for academic curiosity, if someone had very frothy or foamy urine, that's a sign they're spilling a lot of protein. So the specific criteria, so gestational thrombocytopenia is under 150, but for preeclampsia, we want to see the platelet count under 100 is our cutoff. And then if they had a serum creatinine of 1.1 or a doubling of their creatinine compared to their baseline levels that we would have gotten earlier in pregnancy if they had risk factors, that's a trigger. And then if their liver enzymes are twice normal. And I feel like more and more often we're seeing women who have pre-existing fatty liver disease. And so we're seeing some patients that are coming into their pregnancy with elevated liver enzymes. And that definitely makes it trickier if they develop high blood pressure later. Then you're trying to figure out if are they getting preeclampsia, or is this a pre-existing chronic health problem? And so that's why getting those baseline labs can be very helpful. So again, the risks are the same for mom and baby. The main difference compared to the chronic hypertension is delivery a little bit earlier. And then compared to gestational hypertension, we're seeing in this patient the protein being spilled into the urine, and we're more concerned about her developing some of those blood work abnormalities that are showing us end organ damage. So here we'll move on to our next case. So this is a patient who's coming in at 34 weeks. She's a 29-year-old Caucasian, a G4, P2012. So she's at 34 weeks, and she came straight into labor and delivery because she had a severe headache that started today. And so she reported swelling in her feet, her legs and hands for the past 3 days. And I put swelling for the last 2 because we do often see that in someone who's suddenly developing preeclampsia, but it's not part of the criteria anymore. It used to be part of the criteria, but what we found is so many women have swelling in pregnancy, and so many women would get swelling and be afraid they're getting preeclampsia when everything is really fine. So that's not part of the criteria, but it definitely adds to our clinical suspicion that, hey, maybe she's developing something more concerning. So she had gestational hypertension in her last pregnancy with a cesarean section at 37 weeks due to non-reassuring fetal heart tones during an induction for gestational hypertension. And so if someone had any history of gestational hypertension or preeclampsia, we're really going to want to watch these women carefully. And many times, even if earlier in pregnancy, if her blood pressures had started creeping into the 130s, I probably would start seeing her once a week, even if she was at a gestational age when we normally wouldn't do that. So if she was 34 weeks or 32 weeks and her blood pressure was in the 130s and she had that history, that would trigger me to have her come back in a week and recheck her blood pressure, just because we know we're just waiting for her to develop that. So we want to be really on high alert with these cases, just because the morbidity and mortality is so high. So she denies any right upper quadrant pain. She denies any vision changes. She took Tylenol at home, but it gave her no relief from her headache. And she just takes prenatal vitamins, and she's also on that baby aspirin because of her history. So she does have diet-controlled gestational diabetes, and she reports her last blood sugar 1 hour after lunch was 110, which is in the normal range there. So when we get her vitals, her blood pressure is 185 over 112. We repeat it in 15 minutes, and she's 174 over 105. And her oxygen is fine. Her heart rate is normal for pregnancy. Her BMI is 32. And since she went to labor and delivery, they would have put the baby on the monitor right away. And baby has a reactive NST, which means the baby's not stressed despite these very high blood pressures. So when we're thinking about what we're going to do next and what the diagnosis is, so she has severe preeclampsia, or preeclampsia with severe features. So here at Sovah, we have an OB hypertension order set. So that simplifies your life. So that means the higher doses of blood pressure medications that we're getting immediate decrease in the blood pressure, those are started right away. So I can just tell the nurse that I want them to start the OB hypertension set. I'll go over that in a few minutes, and there's options for meds, and I just tell them which med to start with, and they can just follow the protocol. Because you really want to get treatment of severe range blood pressure within 30 minutes. And so we actually look at this here on our labor and delivery when we have our quarterly meetings. All the people that come in with severe hypertension, we actually review the record and see if we're getting them treated within 30 minutes, because we're really working to hit that mark every single time, so that we can keep things as safe and healthy as possible here. And then you would immediately order preeclampsia labs. You'd immediately get a urine protein creatinine ratio, and you can consider starting IV magnesium, which I'll get into that in a minute, to decrease your seizure risk or the development to eclampsia. So here's the medications that you're using in our OB hypertensive order set. So we're using labetalol, but we're using an IV version of that. And then you're giving 10 to 20 milligrams. And then, so typically we do 20, 40, 80. And you should see the blood pressure drop within 10 minutes. So we're checking the blood pressure 10 minutes after it's given. If it's still severe range, then you go up from the 20 to the 40 to the 80. And you can actually repeat that 80 milligram dose until you get to 300. And then you're cut off for maxing out labetalol. And this chart you see here, who you want to avoid it in women with asthma, pre-existing myocardial disease, decompensated cardiac function, heart block, or pre-existing bradycardia. So if you go through labetalol, or if you give a few doses and it's doing nothing, then we consider switching to the next medication. So on this chart, they have hydralazine listed next. Most providers start with labetalol or nifedipine and then move to hydralazine as the third option. The benefit of nifedipine is you can give that without an IV. So the immediate release nifedipine works within 20 minutes. And I've seen people that we recheck the blood pressure at 15 minutes and it's still severe, but then you recheck it at 20 minutes and all of a sudden we're under the level. So I definitely see the full effect, even though the onset of action that we see on the right side is 5 to 10 minutes, you'll see the full effect within 20 minutes. And so then you can give 10 and then repeat to 10. And they typically, they have the max daily dose is 180. We typically don't give more than 3 doses of this if it's given rapidly. And you'll see there where they mentioned doing it every 2 to 6 hours because you don't want to give a lot of that all at once. And we do see headaches with nifedipine. And so that can be tricky if we're using nifedipine to treat severe preeclampsia and then they're getting a headache. You're stuck wondering if that's a headache from the nifedipine or if that's a headache because they have worsening severe preeclampsia. And then the hydralazine, this one also, we recheck the blood pressure. We give it 20 minutes instead of 10. Now, traditionally, we started with labetalol when this first came out from ACOG because it was IV and because it's supposed to work a little quicker. It definitely seems like labetalol does not work as well for African American women, which is talked about some in the non-pregnancy literature. I don't know that I've really seen it in pregnancy. But there have been some studies that show for all women, nifedipine may work a little quicker, even though it's oral and we don't see the full effect for 20 minutes. If you don't have to give as many repeat doses, it may be worth it to start with nifedipine, even if you have IV access. So for this case, as you can see here, I got into the medications, but on this patient, she had severe range blood pressures. We didn't have any labs yet, but with those blood pressures being high, we want to treat it within 30 minutes. And so we start the treatment while we're waiting to get labs. Even getting a stat CMP to get these results back can take a good hour. So you definitely want to initiate treatment even if you don't have labs back because it's the severe range. So her platelets are 120, which is not under the 100 criteria. The AST and ALT are fine. The creatinine of 0.89 is still technically normal, but that is a little bit elevated for a pregnant patient. We often see on new OB labs, their creatinine actually pops up as being abnormally low, and that's normal for pregnancy. And then the urine protein creatinine for her is 0.88, so that's over our 0.3 cutoff. So she has proteinuria, and she has severe range blood pressures, and she had the headache, which she came in for. And so when we look at these criteria, you don't have to wait 4 hours if it's severe range blood pressure. Hers was over 160 and or over 110. And so you start treatment as soon as you get that repeat in 15 minutes. So we often don't count the first blood pressure when they get there is often high. If it's not really preeclampsia, we'll often see it dip, and on repeat blood pressures, it'll slowly go down without treatment. But if they're staying severe, even when they've been sitting at rest for 15 minutes, that's when you really want to start the treatment. And then the other signs that we see from the labs over here. So magnesium, so if their blood pressures are staying severe and requiring treatment with medications, you want to start magnesium. So the magnesium dosing, you start with a 4 to 6 gram bolus IV, and you're giving that over 20 to 30 minutes, which if you're not OB-GYN will seem like a ridiculous amount of magnesium. And then we give 1 to 2 grams an hour as the standard IV maintenance dose. So typically we continue that until they're 24 hours after delivery. So if they're stable to be induced, we may be inducing them, and I'll talk some about delivery planning later. But we may induce them, and even if their induction takes 2 days, if they're stable enough for that, and they were on magnesium that whole time, we still continue the magnesium for 24 hours afterwards, just to make sure we're clear, because the treatment for preeclampsia standard is to deliver the baby. Once the baby and the placenta are out of the mom, most people are going to very rapidly improve. And then if you don't have any IV access, IM magnesium can be given. You give 5 milligrams in each buttocks, which is a lot of magnesium, and they will not like you if you do that. So we got to hope you have IV access. And what this does is it just decreases the seizure threshold. And so you actually see a decrease. You can see a decrease in their reflexes, and it decreases the risk of seizure developing. So the therapeutic range, it's the exact range is debated. Around 4 to 8 is acceptable. Where I trained, we said 4.8 to 8.4 just because it was catchy and easy to remember. But that's where you want it, and that puts them in the severe range. So we'll often get a call from a lab. So if the magnesium is getting 6, 7, and 8, we're going to get a call from a lab saying, hey, their magnesium is too high, but that's where we want it to keep them therapeutic to reduce that risk. So you want to repeat the magnesium levels every 6 hours, and consider repeating labs every 6 hours to assess for HELLP syndrome, which we'll discuss later. Because if the mag levels are getting too high, it can actually be very dangerous. So you can see here, if you get magnesium, we want it to be under that 8, 9 level, because around there you'll see a loss of reflexes. And then when you get to 10 and 12, you'll see respiratory paralysis, and then even cardiac arrest if it gets up to the 20s and 30s. So if we had someone who was getting over 12, you'd be considering moving them to the ICU for management, instead of just keeping them on labor and delivery. Because normally, even with magnesium IV, we just keep them on labor and delivery. When I was a resident, I saw someone with really impaired kidney function, and she ended up with a mag level, I think around 18, and she was definitely rushed to the ICU for closer monitoring and oxygen support. And just because that's something that you really want to monitor to make sure it's not getting too high. And the nurses have a protocol for checking reflexes, and if the patient all of a sudden completely loses their reflexes, we're getting concerned about their mag level. So if we take that same patient who we've been talking about, who had the normal blood work before, she just had the severe range blood pressures and she had the elevated protein creatinine ratio. But this time around, if we took that same one and her labs came back and we were getting a creatinine of 1.6, that bumps her over that cutoff for renal problems. And that makes us more concerned about the severity of her disease. And it also wants to trigger us to watch her magnesium more closely. So if their creatinine is over 0.1 or their urine output is less than 30 milliliters per hour over 4 hours, we would give the same loading dose of magnesium, but we want to decrease that rate to 1 gram an hour, and you want to repeat the level in 4 hours. Because there are some women, if you had a creatinine of 2 or greater, you might be able to give them that loading 4 to 6 grams over 20 to 30 minutes, and that may be enough magnesium, and they're going to clear it so slowly that they may not have to get any maintenance rate. That may keep them good for almost 24 hours. So I would still, even if I didn't give them the maintenance dose of 1 gram an hour, if their creatinine was really high, I would still repeat that mag level in 4 to 6 hours and see if we do need to start the maintenance rate. But otherwise, it's the same management for preeclampsia with severe features, because it doesn't change that, because her liver enzymes were still fine, her platelets were still fine. It was just the creatinine bumped up to make us adjust our magnesium dose. And for non-OB people that are watching this, if you're seeing this in the ER, typically you just have to give them that maintenance dose and maybe start the initial blood pressure meds, and then you're calling OB to get us to take over, and you're not having to think about maintenance, hopefully. So for delivery planning, so remember this patient, our earlier patients that we were talking about delivering, we were talking about at 37 weeks, but this patient was 34 weeks, and delivery is indicated at 34 weeks or time of diagnosis if there are severe features. So the mode of delivery, or whether you're thinking vaginal delivery or cesarean section, that's based on normal consideration. So if baby's heart rate looks okay on the monitor, mom hasn't had a prior C-section, if she's had a couple vaginal deliveries before, you could still start her with the normal induction medications that I won't get into today and try to induce. If we were worried about her developing HELP syndrome, or baby's heart rate was not reactive or not category 1, we would consider a C-section for those reasons. And then if they're under 37 weeks, you can consider giving IM betamethasone when starting the induction, and that can improve fetal lung maturity and make it less likely that the baby's going to need a long NICU stay. So if the gestational age was under 34 weeks, but otherwise the same patient, then we would try to delay delivery until 34 weeks gestation. So you would give the betamethasone, we do a 12 milligram dose and repeat it 24 hours if we think the delivery is going to happen in the next week. So the max benefit of that steroid giving us improved fetal lung maturity is 2 to 7 days after the first dose. So we would, ideally, you're able to give them the 2 doses 24 hours apart, and then they deliver 24 hours later, and that would really maximize the fetal lung maturity. But some people, even if we think they might deliver by C-section in the next 12 hours, we may still give that first dose of betamethasone, just hoping to get a little bit of improvement for baby. And then induction of labor before 37 weeks may take days. So when we're inducing people at 39 weeks, a lot of women are going to be delivering within 24, 36 hours. But the earlier the induction, you can see it really take a long time. And so that increases the chance of it ending up with a C-section. And so the risk of C-section increases the earlier you go, and it's as high as 96% if under 28 weeks. So there may be some places where if you're severe preeclamptic and they can't get under control, or you're moving toward help, you may be delivered by C-section at under 28 weeks and never given a chance for induction, just because the chance of you actually delivering vaginally is so low. It's not worth the risk. So the reality for delivering for us here in Danville, if they're under 35 weeks and they're stable, we would transfer the patient while they are still pregnant to a facility with a NICU. So for us, that's often Carilion. So that 34-week patient, the reality here is we would not want to keep her here. We want to get her out as soon as we can. There are cases at 35 to 37 weeks where we might consider transfer if we're able to make it happen quickly. If we're worried about the baby having an increased chance for a NICU stay, which is always increased if they're under 37 weeks. And then typically for any kind of maternal problem in pregnancy, if they're 37 weeks and greater, usually the baby does well and we can keep them here in Danville. And then again, for delivery here, we would prefer to get them out while they're still pregnant and keep the mom and the baby together. But if there's an unstable condition and we had to do an urgent or stat cesarean, we might perform it here even way under 35 weeks, because we can do the C-section here. We just don't have the NICU capabilities. So oftentimes we get a NICU ambulance that comes down, and our pediatricians and nurses stabilize the baby until they can get transferred. The downside for the mom is while the baby's off to the NICU immediately after delivery, because it's a hypertension maternal problem, the mom is stuck with us usually at least 48 to 72 hours while we make sure she's stable before she's discharged to go be with her baby. Any questions at this point? All right, I'll keep moving so we have time for everything.
A question just popped up, Dr. Hanea.
Yes.
Dr. McIntosh, do you have a microphone? Do you want to read this? No? Okay. It's from Dr. McIntosh. Good evening, everyone. Dr. Obenazi, we both went to St. George's University School of Medicine. Excellent presentation and refresher for internal medicine hospitalists and nocturnists. Looking at this topic from a health equity lens, what measures are being taken in your practice to address the social detriment of health which negatively impact African American females, leading to elevated BP readings, gestational hypertension, preeclampsia, and eclampsia? One of the most dreaded consults in my almost 20 years of practice was being called to labor and delivery floor for one of those cases. Thank you so much.
Yes, so I actually semi-regularly have conversations with African American women, because if they meet those criteria for aspirin, which I'll show you later, then I'm talking. So if it's their first baby and they're African American, or if they're African American and they're obese at the beginning of pregnancy, or a multitude of other things I'll show later, if they have increased risk for preeclampsia, I'm starting them on baby aspirin at 12 weeks. And so I'm explaining to them why we're starting them on that. And I remind women who are African American, in this country, just because of the color of your skin, I know you're more likely to have higher maternal morbidity or mortality. So you're more likely to have health complications or even death just because you're African American. So knowing that, we're going to watch you really closely. We're going to get baseline preeclampsia labs. We're going to start you on aspirin. If anything is suspicious, we're going to do more frequent visits. And I feel like I see it in the news regularly, where we hear about, some African American woman who died with preeclampsia, or died with HELLP syndrome, or died with cardiomyopathy. And it's amazing to me how many patients who are African American women don't realize their own risk with that in this country. A lot of people just think, oh, I'm pregnant. Everybody gets pregnant. Most people do fine. I don't need to worry, but it can be dangerous. And so that's something that we definitely look at and watch closely. And with women meeting criteria for aspirin, that's a good segue to explain to them what the risks are and make sure they're aware, and they're being proactive and seeking help if they're having any of those symptoms, like the severe headache or the vision changes or the right upper abdominal pain. We can go over that early because we're triggered into that conversation with the baby aspirin. So moving on from there, so if we take the same 34-week patient who we've been looking at, but let's change her labs again. So 6 hours after starting magnesium, we repeat her labs. And before, her creatinine was a little bit up, her urine protein creatinine was a little bit up, but everything else was okay. This time, her platelets are under 100, her AST and ALT are now more than doubled, her creatinine is up to 2, and her LDH is elevated. So now when we see all this, we're seeing a whole nother diagnosis beyond severe preeclampsia. And so now we're seeing HELLP syndrome. So this is considered by many a more severe type of preeclampsia. And HELLP stands for hemolytic anemia, elevated liver enzymes, and low platelets. And so you want to see all of those to meet criteria. So it usually presents with severe right upper abdominal pain, and they often just feel really fatigued. They feel bad. It can present with nausea and vomiting. And here's the interesting part with HELLP syndrome: about 15% of patients will have normal blood pressure and no proteinuria. And sometimes we catch these patients before it's full on HELLP, but we might catch that the liver enzymes are going up, or catch the creatinine is becoming abnormal. And then we often will call them like an atypical preeclampsia, and we watch them really closely and see if it develops into HELLP syndrome. But you can get HELLP without initially having preeclampsia. And with the general malaise and nausea and vomiting, a lot of women, if they have HELLP syndrome or they have preeclampsia with severe features, they look sick. And so, and a lot of you that have been practicing for a while, there's some people that you just walk into the room and they just do not look like they're well. And that's the look you get with preeclampsia and HELLP syndrome. You definitely walk in, and a lot of them have a lot of facial swelling. They just feel awful, and they look really sick. So with HELP syndrome, you want to deliver as soon as the mother is stable. So an urgent C-section if she's hemodynamically stable and if the coagulopathy is corrected. And you can even consider transfer to tertiary care center at any gestational age due to the risk of DIC. And I think here at our hospital, I'm fairly certain even in the last year or two, we've transferred people who were at a gestational age where we could have kept them. Because of HELP syndrome, we were able to get urgent transfer, and we transferred just to be somewhere with more blood products and able to really make sure if things go bad with DIC, you're not doing a C-section on someone with DIC. So management's the same as preeclampsia with severe features, in addition to correcting the coagulation and rapid delivery. And so that would be typically giving platelets and making sure that they're stable enough for C-section, which usually at her level here, her platelets were 89. So we would that's still stable enough to do a C-section. We really don't get anxious about it unless it's under 50. That's where you really just don't want to touch them with anything sharp. Other questions at this time?
Nothing in the chat.
Okay. So moving on to the next case, a labor and delivery call. If you got paged from labor and delivery that a 40-year-old G5 P2022 at 33 weeks just arrived via EMS who had a witnessed seizure at home. She receives her care at an outside facility and no records are available. And that scenario happens more than we would like. She's awake, but she's drowsy and she's not really responding coherently when she's asked about symptoms or health history. And so we often see that post-ictal state in someone who just had a seizure where they just aren't making sense, and it makes it very difficult to talk to them about what's going on. So her partner reports that her OB has been watching her blood pressure, but she's not on any medications. Her initial blood pressure was 210 over 120. The repeat in 15 minutes was 205 over 115. And these are levels that we really do see on occasion here with severe preeclampsia or eclampsia. So her heart rate's 95, her oxygen level is good, her BMI is 45, and her baby's heart rate, the baseline of 125 is normal, but minimal variability means that that baby's heart rate is pretty flat, that we're not seeing the little ups and downs that we want. And when you're seeing late decelerations, you're concerned about the blood flow not going through the placenta like it should. So if I'm seeing late decelerations and I'm seeing blood pressures with systolics in the 200s, I'm immediately thinking about that placental abruption that we talked about earlier, where your blood pressure is just getting so high, you can think about it basically pushing the placenta off of the uterus. And with a seizure, even separate from blood pressures being high, a seizure makes you high risk for placental abruption. So here, when you're thinking about management, you want to be starting the OB hypertensive order set. You want to be starting IV magnesium. You're ordering your preeclampsia labs, and you're thinking about a stat C-section. So the reality in these situations, you have an OB, and as many nurses as available are in there starting IVs, collecting labs, getting the IV magnesium, putting in a Foley, moving toward a C-section. Everything is moving really quickly because we want to get this baby out safely, and we want to get the mom stabilized. So we would call a NICU to accept transfer of the neonate because of how early they are. We would continue the magnesium for 24 hours after delivery, and we would likely be starting a long-acting antihypertensive medications if that blood pressure did not come down after the C-section. In situations where we're doing a spinal for a C-section, sometimes we're not super aggressive with blood pressures because we know that spinal anesthesia is going to drop the blood pressure for us. In her situation, if it's a true stat, we're doing general anesthesia. We're a little bit less likely to see that drop, and so we're more likely to be being really aggressive with our blood pressure management. And then you would repeat labs for 6 or 12 hours after that first set. So in that situation, even once she's delivered, she's still on magnesium. We want to be monitoring her labs and making sure that things aren't getting worse. So seizure treatment in pregnancy, the magnesium does not actually treat a current seizure. It just prevents a recurrent seizure. And so benzos are used for the treatment of an acute seizure. And one of the basic ones that's recommended is lorazepam 4 milligrams IV, and it's given over 2 minutes. So for her, since she came in post-ictal, we wouldn't be giving her benzos, but we would be starting the magnesium. So now that brings us into postpartum care. So we often repeat preeclampsia labs for 1 to 2 days after delivery. We would start antihypertensive medications if needed, and we would do daily blood pressure monitoring for 72 hours after delivery, which is ACOG's recommendation. So they're usually inpatient for 48 to 72 hours. If they leave before 72 hours, we want to make sure there's someone who we know can show up the next day at the office for a repeat blood pressure check to complete that 72 hours of monitoring. And then even if we keep them for 72 hours, our office will typically see people within a week for a blood pressure check after discharge. So moving into postpartum problems with hypertension that we see, this is an emergency room call. And so a 24-year-old G1P1, so she already delivered, she's postpartum day number 4. She presents to the ER after being discharged in stable condition 2 days ago. So she states that she had worsening swelling and shortness of breath since she got up that morning. She denies any problems at all in pregnancy, but she tells us that her water broke at 37 weeks and she had a 2-day induction, and then she ended up with a C-section. So when we get those initial vitals, that initial blood pressure is 164/89. So that's severe range. So we're concerned. We repeat it in 15 minutes. It's down to 150/82. So not severe range, but still definitely elevated for pregnancy and preeclampsia. Heart rate is fine. Her oxygen's a little bit low for someone who should otherwise be a healthy young person, and her temperature's fine. So the only significant physical exam finding is she's got bilateral lower extremity pitting edema. So now we're thinking about, okay, she's postpartum. It should be less likely to be preeclampsia. Her blood pressure is not severe. Her oxygen's a tiny bit low. So now you're going to get labs and imaging. And this is usually done in the ER, sometimes before we even get the call, they're doing all the workup if the blood pressure comes down. So usually at least the labs are done. You would get a D-dimer and a BNP. A chest CT was done, and that did show bilateral pleural effusions, but no pulmonary embolism or pulmonary edema. The reality is the echocardiogram probably wouldn't be performed. It's unlikely to get it that same day, but one was done and the level's 65%. So now what are we thinking for diagnosis? If her preeclampsia labs, D-dimer, BNP are normal, she's got bilateral pleural effusions and swelling, and her echo, her ejection fraction is looking good. So the options that we're thinking about, postpartum preeclampsia can happen after the delivery. We're worried about a pulmonary embolism. We're thinking about peripartum cardiomyopathy. These have all been ruled out with the labs and the imaging. So she's just postpartum fluid overload. So with that, you get people that look like they're developing these other things, but you can just get a fluid overload as all those fluid shifts and all those cardiovascular changes I talked about at the beginning of pregnancy. There's a significant cardiovascular changes that are happening in that first week after delivery. So normal fluid shifts and cardiovascular changes lead to a peak blood pressure about 3 to 6 days after delivery. Many women have increased swelling around this time. I actually try to warn all of my patients that I'm discharging, hey, expect to have some swelling, 3 to 5 days after delivery. And I give them things to be cautious about, like, shortness of breath, chest pain, things like that are associated. And the initial presentation of fluid overload often looks like postpartum preeclampsia or cardiomyopathy. So in these situations, we would admit her for 23-hour observation and diuresis. And so we would repeat preeclampsia labs. If her vitals are stable, we may wait till the next morning to repeat them. We would consider a chest x-ray based on the oxygen saturation. And then we would consider discharge, and usually in a day or two. And we often will give something like hydrochlorothiazide or Lasix that they might take just once a day for the next week, just to help them get that fluid off. The downside of these meds is they can decrease milk supply. So I warn my patients about that. And if they are breastfeeding, we may give them as low a dose as we comfortably can to try not to affect the breastfeeding, but also not to put them at cardiovascular risk. So preeclampsia and eclampsia can present postpartum. The diagnosis and management is the same. We do magnesium. If she really was postpartum preeclampsia, we would do magnesium for 24 hours. And if their symptoms weren't improving or labs weren't improving, we might continue it for more than 24 hours. And then even once we've stopped magnesium, we often keep our patients for 12 to 24 hours after stopping the magnesium just to make sure they're stable, maybe repeat some labs, and then get them discharged. So I mentioned earlier is with the aspirin that we give starting at 12 to 16 weeks, we continue until 36 weeks or at least 5 days before delivery. And that can reduce your preeclampsia frequency by 10 to 20%. So here are the risk factors. This may be hard to see depending on the screen you're looking at, but these are a lot of things. So this first row here, if they have 2 or more of these, and this is first baby, BMI over 30, Black race, even a family history of preeclampsia puts you at risk. And then the other side, if they just have one of the risk factors on the right side there, then we're starting aspirin. So that's a significant number of our patients in this area who are putting on aspirin to try to decrease that preeclampsia risk, even if, even 10 to 20% is still a move in the right direction. And that is it. What questions or concerns do you all have for me?
Okay, we have a question in the chat. Is a low vitamin D level a risk factor for OB, hypertension, and or preeclampsia? Do you measure serum magnesium as a part of the routine prenatal labs?
So we don't do a magnesium level as part of the prenatal labs. And I have seen, I feel like I've seen some articles where people have looked into vitamin D as low vitamin D as being a potential risk. But as you can see with the criteria for low dose aspirin, it's not hitting the list here. And so it's not significant enough, or there haven't been good enough studies done to make us consider that as part of the risk. And we often don't check a vitamin D level at the beginning of pregnancy.
Thank you.
Dr. Nez, Dr. Moore again. One of the things we used to get as a consult at the urologic clinic back in the day when I was regularly seeing patients were women who had delivered a baby, not really overtly, I guess they probably had some degree of preeclampsia, but they would be referred to us because they were hypertensive after the baby, yet they had not been thought to be hypertensive before the baby. Of course, that was back when we used different criteria. If the blood pressure's up with preeclampsia, how long can you wait until you say, well, yes, the lady really does have, after the baby, chronic hypertension? Perhaps they didn't have it before, assuming their renal function's normal. Are there guidelines about when it becomes chronic, or when that, if you will, pregnancy-related increase in pressure should dissipate?
So, and I have not seen a hard and fast rule across the board. Typically, if someone is still requiring blood pressure medications at their 6-week postpartum visit, so routinely we see patients at 2 weeks and 6 weeks. So if it's still high at 6 weeks, then either I'm referring my patients to follow up with my family nurse practitioner in the office to take over blood pressure, or I'm sending her to primary care. And some of the women with chronic hypertension, after 6 weeks, we bounce them back to their primary care to take over management, because then they might be able to go back on some of those other meds that we don't want them on in pregnancy. But usually 6 weeks is our cutoff for saying, okay, this is probably not going to go away with a little more time, so you're going to be on this medication for a while.
Yeah, that's pretty much what we did. And of course, the real message is they need ongoing follow-up. You can't just assume it's going to dissipate, and you really need to follow up like you're outlining. It's really great. Mary, was there another one
yes.
that popped up?
There is. This is from Dr. Singh. Great presentation, Dr. Honea, with case scenarios. Any other recommendations if a patient's allergic to aspirin?
And I have not seen anything. That's a good question. We're kind of stuck at this point. And if anything, yeah, I haven't seen anything alternative to aspirin. And there's actually been studies looking at whether we should increase the dose of aspirin, and maybe we should be putting these women on 325 milligrams, not just 81.
Okay, thank you.
Any others in the chat? Anyone on the call? Please speak up. You've got the expert here on the line. I know a lot of you on the call are either primary care providers and or you're working with perinatal ladies. Any questions or comments at all from anybody? Okay, well, Dr. Anea and Dr. O, thank you all so much. Great program this evening. Really, really good practical information. We hope everyone on the call will be back and join us in about 2 weeks when Dr. Friedman will be talking about the emerging information on the genetics of chronic kidney disease and ways we can better help our patients prevent end-stage renal disease. Thanks to Mary and Van Holt for getting the program together. We hope each of you have a great evening this tonight. Of course, the basketball games have restarted, and the good folks at Duke will play Arizona about 9:40 tonight. So you got plenty of time to get ready for that. Otherwise, as I remind our, please be careful out there, and we hope to see you back in a couple of weeks. Have a great evening. Bye-bye. Good night. Thanks so
everyone.
much.